Hi, my name is Dr. Alicia Morgans, and I am a genitourinary medical oncologist at Dana-Farber Cancer Institute in Boston in the US. I'm so pleased to be joined today by Dr. Grace Cullen, who is a nurse practitioner at the John D. Dingell VA Medical Center in Detroit, also in the US. This is one of 3 discussions that each follow a unique aspect of managing patients with metastatic castration-resistant prostate cancer who are undergoing PARP inhibitor therapy. Today, we'll talk about the data supporting the use of PARP inhibitors in metastatic CRPC and how this can be applied to clinical practice. So thank you so much for joining me today, Grace. I'm really excited to talk with you about PARP inhibitors and some of the ways that we really integrate these into our clinical practices.
Same here.
Wonderful. So let's start off by talking about which patients actually are able to get PARP inhibitors, and is this a majority of patients that we end up treating, or are there some disparities or some barriers to patients who might be eligible getting all of the therapies that they can?
There's certainly clinical indications for the use of PARP inhibition. Certain tests would have to be conducted to find out which patients would qualify. And certainly because although it's been out in the market for a number of years now, there's still some need to educate patients on what these diagnostics are and why they are necessary in order for us to find out whether targeted therapy will be appropriate for certain populations.
Absolutely. When I think about it, I really think about trying to uncover these patients and find them, which is usually done by germline and somatic genetic testing. And in order to find the patients, we have to do those tests because really these drugs are indicated for patients who have either BRCA1, BRCA2, or one of a number of other HRR or homologous recombination repair defect mutations. And so we have to do the testing to find the patients. When I think about mCRPC overall, though, I think we recognize that we're undertreating a number of patients and that with each line of therapy, there's a drop-off of about half of patients not receiving treatment. So it's so critical that we find these patients so we can really try to avoid that drop-off and make sure that patients who may benefit do get the treatments that are approved. When it comes to approvals, I know that PARP inhibitors are actually approved as both monotherapies and also as combinations. Would you mind sharing the monotherapy labels for the U.S.? And we can consider that these might differ around the world, but at least in the U.S., we have a couple of options.
Yes, so monotherapy might be indicated for those who've had progressions following androgen deprivation, combined with perhaps an ARP or androgen receptor inhibition. That would be one of the populations that we might consider doing monotherapy of a PARP inhibitor.
Great. So olaparib is approved as a monotherapy in patients who have had progression of disease after an AR pathway inhibitor. They could have had prior exposure to docetaxel chemotherapy, but they don't have to have had that. And it is available as a monotherapy for patients who have a number of those HRR mutations like we talked about earlier. We have a little bit of a narrower monotherapy indication for rucaparib, which is actually approved in patients who have already received treatment with an AR pathway inhibitor and a taxane chemotherapy. And it's only approved with that drug for patients who have BRCA1 or BRCA2 alterations. So a little bit of a different indication. But like you said, we can also use these agents in combinations. And we know the combination indications are olaparib in combination with abiraterone for patients who have BRCA1 or BRCA2 alterations. Patients have to have had progression on ADT. They could have had prior exposure to taxane in the hormone-sensitive metastatic setting, but really this is a first-line mCRPC setting, and patients should not have had prior exposure and progression on an AR pathway inhibitor. We also have the combination of talazoparib in combination with enzalutamide. In this setting, also that same first-line mCRPC setting in patients who have had progression, usually on ADT, maybe docetaxel in that metastatic hormone-sensitive setting, but not a large exposure, at least in the clinical trials, again, to the AR pathway inhibitors. Here, though, the indication is a little bit broader. This is for patients who have HRR mutations more broadly, not just BRCA1 and BRCA2. And then that third combination approval is niraparib with abiraterone acetate. Again, first-line mCRPC setting. So most patients in the trials at least had progression just on ADT, maybe with some docetaxel in that metastatic hormone-sensitive setting. And in this combination, niraparib abiraterone is also approved in patients who have BRCA1 and BRCA2 alterations. So I think as we're trying to use these in clinical practice, we're really thinking about use in a metastatic castration-resistant patient population, sometimes as monotherapy, sometimes in combination. And as we're first getting familiar with that, of course, we're referring back to the guidelines in wherever someone lives, whether that's NCCN, if we're in the US, or the European guidelines, if we're elsewhere, can be really, really helpful because there are some nuances that we do have to think about as we're making these treatment decisions.
To add to that, as you have indicated, we have multiple options as far as treating these types of patients. I think taking into consideration comorbid conditions, the burden of enhancing androgen deprivation for certain patients might be more burdensome than others. So having that shared decision-making, considering comorbid conditions, potential side effects of these agents as you pick the best combination or single agent of choice will also be very crucial.
I think that's so important, Grace. I wonder if you can just elaborate on that. Which comorbidities do you think most about? And then certainly when you're treating patients, what are some of the comorbidities or other complications that you think about as you're monitoring and maintaining patients on treatment?
So certain agents, particularly enzalutamide has been associated with some seizure-like activity. So if I have a patient with a history of seizure disorder in the past, perhaps traumatic brain injury, I would have a very thorough discussion with the patient and perhaps consider alternative agents in that situation too. Abiraterone has had limited trials for patients with underlying heart failure. So I would be also having that discussion with the patient, perhaps, obtaining some pre-treatment diagnostics, establish some baseline data before picking the best people for patients for this type of agents. And certainly the burden of taking multiple medications is not something that I take lightly either. Patients tend to consider perhaps the most convenient choices whenever it's possible. So for certain types of patients, they might have their individual choices and individual situations we have to consider.
Absolutely. When I have patients on these combinations or single agents, one of the things that I think about is always monitoring blood counts because PARP inhibitors can cause some cytopenias, particularly anemia, sometimes thrombocytopenia. And sometimes patients need either dose reductions, dose modifications, or transfusions. And other times we also need to think about working up other causes of anemia to perhaps reverse other reversible issues to ensure that patients can stay on treatment. Is that something you see in your practice, Grace?
Yeah, definitely. The option of staying on a regimen and just doing those reductions is always there. You want to try to utilize these agents to the best of their abilities. I don't see very many of those toxicities or side effects, but it can happen. And your approach to a dose modify is certainly appropriate.
Wonderful. As we continue this conversation, though, I wonder if we should think about putting all of this knowledge into the context of a real person and think through a case.
Yeah, I completely agree with you. So for instance, if we are seeing patient who's 72 years old in practice, who perhaps may have been diagnosed with prostate cancer about 9 years ago, previously treated with docetaxel and an AR pathway inhibitor, now recently found to have bone metastasis, also has a coexisting family history of breast and ovarian cancer. What in your practice would be your typical next steps?
Yeah, these are very common situations that we have when patients are treated initially and then develop that progressive disease. And it is also, of course, not unusual for patients to have family history of other cancers. So in this setting, I think it would be really critical to think about germline genetic testing, which actually we do for patients with metastatic prostate cancer, regardless of family history, regardless of age of diagnosis, because we know that they have a high enough risk that screening for patients with metastatic disease is well worthwhile and is in the guidelines for germline testing. We would also, of course, want to do somatic testing because this may find those mutations that may be unique to the prostate cancer, but not necessarily heritable, and would give us another opportunity to find mutations that may be targeted with things like PARP inhibitors. Interestingly, 50% of our mutations are found in germline testing, 50% are found in somatic testing, more or less. And so doing both of these testing approaches is really, really important. if we did find germline mutations, I think we would want to talk to this patient's family as well to make sure that they're aware. But as we do all of that testing, we could identify whether the patient may undergo treatment, perhaps with something like a PARP inhibitor. And then we would want to talk about all of the things that you mentioned earlier around comorbidities, concerns for side effects, and the management and monitoring process to make sure that we made a shared decision with the patient to choose the treatment that was right for him.
I completely support all those steps, Alicia. Germline testing is certainly an option for these patients, especially given the strong family history, which would not only be beneficial to him, but family members potentially for early diagnosis and better outcomes.
Great. So we talked about so many things, Grace. I wonder if you could share from your perspective, what are some of the key points that you want everyone to think about as they come away from this discussion?
To consider that every patient is unique and have their own individual circumstances, not just medical, but personal, and to make sure that they're very much involved and engaged in shared decision making. I always tell trainees that a treatment is only as good as long as the patient is able to take them. So if the patients are not able to take them, no matter what the data is showing, it would not work for that particular patient.
And when I think about PARP inhibitors, whether it's monotherapy or whether it's in combination with an AR pathway inhibitor, I think that understanding which patients may be eligible through germline and somatic genetic testing is critical and the key point here, but also having those shared decisions around whether a patient wants to or is able to, from a clinical perspective, use the combination or use a single agent, and what makes most sense for the patient, the cancer, and certainly for that forward-thinking process is the right choice for him and for his family too, because no one is in this alone. So thank you so much for this discussion. I really look forward to the other sections. Hi, my name is Dr. Alicia Morgans, and I'm a genitourinary medical oncologist at Dana-Farber Cancer Institute in Boston in the US. For this part of the program, Dr. Cullen and I are pleased to welcome Professor Albrecht Stenzinger, pathologist at the Institute of Pathology, University Hospital, Heidelberg, Germany. In this section, we will be discussing the role of precision medicine in guiding PARP inhibitor use. A key factor in PARP inhibitor use is confirmation of BRCA or other HRR mutation status. So let's get started. I think, to begin, as I consider, finding these patients, that is the critical piece. We have to find these patients. And Grace, I wonder if you can share with us how important is that piece and what do you do to find these patients?
Right now, at least in the United States, there's certain clinical indications for which patients would qualify for germline and somatic testing. In the setting of prostate, your metastatic castrate-resistant prostate patients will be good candidates. We are also utilizing it for very high risk and high risk cases of prostate cancer. Certainly taking into consideration other factors such as a strong family history that potentially might have a genetic link. These patients will also be good candidates. And ancestry will also be something that you take into consideration. There's also a reason to consider testing for certain patients based on the histology when we look at that biopsy and the features of the specimen that we're looking at.
In Europe as well as in Germany, we have guidelines regarding testing of prostate cancer patients. Of course, most of the testing is still tumor-only sequencing, meaning that whenever we run into a scenario where we see a, potentially deleterious BRCA1 variant, for example, we would subject this individual to genetic counseling and subsequent germline testing. And for those programs where we run, both somatic and germline testing anyway, we are reporting, germline events as well as the somatic events, and then the data are being discussed with the medical geneticists in terms of genetic counseling.
Great. Thank you for walking us through that. And yes, it does differ a little bit between the US and the rest of the world when it comes to guidelines. But in general, it is really pretty much standard that we are recommending germline and somatic testing for metastatic patients at a minimum. Grace, when you're in clinic, how do you think about performing this testing just in a really pragmatic way?
Definitely, obtaining a very thorough history is very important. That's how you find out about the family history that might be coexisting in this particular patient. And going over, the different criteria for classifying this disease to whether it's high risk, very high risk, or metastatic is also very important. And again, having that discussion with the patient is also very crucial.
Agreed. When I'm in clinic, I often am referring patients to a rapid genetic testing for germline testing, and they typically do a blood sample. But we also have access to potentially getting a saliva-based germline genetic test, which can be very, very helpful for some patients as well. What I use for somatic tends to vary by the disease distribution. I'm sure it does for you too, Grace, that sometimes we have access to the primary prostate tissue as the best source. And if the biopsy was done within the last couple of years, because it is typically a truncal mutation, these HRR mutations are typically truncal, we can often find them in the primary prostate tissue. But sometimes we have to go to things like ctDNA testing or circulating tumor DNA testing, sometimes called a liquid biopsy, because when patients don't have adequate tissue or the tissue is very old and is no longer viable, and the individual has only bone metastatic disease, it can be very challenging to get a new biopsy and then to do the testing. I wonder, Albrecht, if you can share your thoughts as a pathologist on the concordance between tissue-based testing and circulating tumor-based testing.
For tissue and liquid biopsy based approaches, I think it's fair to say that probably a hybrid capture based sequencing approach is best suited to actually interrogate the genes you're most interested in. There are some differences here, though. One, on the tissue side, you don't have to sequence as deep, so maybe a coverage, a read depth over locus around 300x should be all right if you consider 30% humoral cellularity. Make sure that when you're sequencing FFPE material, that you consider that formalin actually creates deamination artifacts leading to C to T transitions, which cause kind of mutations, which are artifacts and need to be filtered out. So the limit of detection usually is around 5%. If you use molecular barcodes, you can go a little bit lower, maybe around 2 to 3%. And then for the liquid biopsy field, obviously, your input material very much determines your results, as well as the technical setup in terms of the sequencing depth. Here at our institution, we use at least 5,000 X over locus after deduplication. Other centers might have different approaches. In this context, I think it's very important that you are using a validated assay where you know what the assay is capable of and where the limits are in terms of, sensitivity, specificity, and other test performance parameters.
Absolutely. I think that having those paired assays, as you mentioned, is so critical because when we're thinking about something like CHIP, which can be an interference in circulating tumor DNA, this is going to be especially a problem on the larger genes, things like ATM. Having the ability to subtract out what is really just interference or CHIP, rather than being a true mutation, is just so critical. So thank you for bringing that up. Grace, I'd love to hear your thoughts about this concept that we keep reminding ourselves of throughout these discussions, which is the unmet need in terms of testing and the people that we are missing. What are your thoughts on our testing? Are we there yet in terms of making sure that all patients are tested for possible use of PARP inhibitors?
I think we're making some progress, but there's still some work to be done. If you look at the data on studies conducted among providers and their utilization of these diagnostic tests, there's still some area of need to enforce it. And I also encourage providers, if there's any areas of uncertainty in terms of genetics, use the benefit of resources available to you, collaborate with your genetic counselors that can educate you on whether something would be indicated and what things to look for, as well as educate the patients as well. And I think educating the patients as a provider is very crucial. I know there's some hesitancy on some population of patients in terms of participating in genetic testing. It's a newer technology, if you will. Patients sometimes are hesitant about participating. So I think being very clear when we educate patients is very important.
Thank you so much for talking that through with us, Grace. I think that patients can have a lot of concerns, and it's really, really important that we help to guide them and allay their fears. Albrecht, I know you talk more to clinicians than to patients, but are there any kinds of reassurances or support or words of wisdom that you provide to clinicians to help them feel comfortable if they've not done genetic testing routinely in their practice, but really are planning to do it? Are there any words of guidance you offer?
I personally think that the network within an institution, but also, outside campus is very critical here. So, for example, at our site, we have centralized a lot of the molecular profiling, but many patients are actually treated outside our institution, in private practices or local hospitals in the region which we are serving. And therefore, a network with proper communication between the clinicians as well as the pathologists, medical geneticists, and all the other stakeholders is very critical. And secondly, the pathologist or the lab that is performing these analyses should know their assay inside out, pros, cons, limitations around the assay, so that you don't run into a kind of black box phenomenon where a certain report is being generated without anyone really understanding, how this report was created in terms of the test that's standing behind it. And that, I think, is very critical because, for example, in the liquid biopsy arena, you might have a negative, a wild type result for a certain patient. And then it's very crucial to understand that maybe the, sensitivity is not sufficient. And so that could still be a false negative result, actually. And, communicating these aspects to the clinician, which then allows to manage the patient, maybe also order some retesting with a different approach. These are very critical and very much influence the patient's journey going forward.
Great words of guidance, and great to know, I think, from a clinician's perspective, that the pathology team has their back and is there to support them too. So, Grace, if you had to give a key point for someone to take away from this section, what would it be?
Reinforcing education is very crucial. Again, driving home the point, this is standard of care now. This is not an experiment, and there are a lot of benefits to doing this is very important.
I think that's so helpful for patients as they're trying to think this through. So thank you. And Albrecht, what would your key point be for this section?
You can probably, narrow that down to two major aspects. One is, from a technical standpoint, know your assay. And secondly, communicate appropriately.
Great messages. So know your test, know your assay, know what to do with it, but also know your patient, because your patient will share concerns and will help you understand how to best meet him where he is in terms of getting the testing that will make a difference for him. Thank you. Hi, my name is Dr. Alicia Morgans, and I'm a genital urinary medical oncologist at Dana-Farber Cancer Institute in Boston in the U.S. For this part of the program, Dr. Cullen and I are pleased to welcome Mr. Tony Collier, a patient advocate from Tackle Prostate Cancer in the UK. We've covered this in our other discussions in the context of the treatment algorithm, but now we will specifically focus on the importance of patient engagement when using PARP inhibitors. Let's dive right in. So, Tony, I think I'd really like to hear from you when we think about patients like the one we heard about before who has had treatment for his prostate cancer over time and now is facing progression of disease and consideration of something that's really new, maybe personalized and targeted, just different to what has been used in the past. What are the kinds of things that you as a patient want to know, want to ask questions about, want to think about when you are considering things like PARP inhibitor therapy?
Yes, and thanks for that, Alicia. I think the most important thing from most patients' perspective will be about how long a treatment is going to prolong our lives, but also what impact will it have on our quality of life? What will the side effect profile look like? And so those are the key things for me.
Yeah, I think I heard through the grapevine that you have been really active in your life, maybe running marathons and exercising. And I can imagine that those kinds of activities or anything that's important to you in your day-to-day life might be something that you want to ask about.
Yeah, absolutely. When I was first diagnosed with stage 4 prostate cancer, the first question I asked my oncologist wasn't how long have I got to live, it was will I still be able to run? And thankfully his answer was yes, and you must. And so ever since then, I've been very much a patient advocate for the value of exercise for people living with and beyond cancer.
And I think that's a good example of, taking into consideration what patients' priorities are, because each patient is unique in terms of what their priorities are and what's most important to them as they contemplate on their options for treatment. So, Alicia, would you like to talk about some more about the efficacy that we have seen in the data coming back regarding PARP inhibition?
Sure. I think when we think about it from the big picture perspective, right, these are really drugs that seem to control disease with a number of HRR mutations, but most especially in patients with BRCA1 or even more than that, perhaps BRCA2 mutations. This is actually a good thing from my perspective because BRCA2 alterations are the most common alterations that we see in prostate cancer. And we really saw some important data from the Triton-3 trial a couple of years ago when we saw the only head-to-head comparison of PARP inhibitors versus docetaxel in that trial. So we've seen PARP inhibitors versus AR pathway inhibitors, but Triton-3 was really the only one that gave us that great comparison against chemotherapy. In that comparison, PARP inhibitor, and in this case, it was rucaparib, hands down beat docetaxel. And I think like other therapies that we have in prostate cancer, the earlier we are able to integrate these medications into the treatment algorithm, the better. And we know that this personalized approach, kind of targeting that specific genomic pathway, is an effective one in metastatic CRPC. So not one that we should really say, oh, let's save this one for later.
I mean, each man is unique, and I think their prostate cancers are unique. And I think that's why targeted therapies like PARP inhibitors are going to become much more important as time goes by.
I agree. And what are some of the things in terms of side effects that we watch for in patients? And of course, acknowledging that different patients are going to have different degrees of these effects.
So there's some common side effects related to PARP inhibition, but I also want to go back to what the data is showing. As far as not only are some of these agents found to be more superior to, more traditionally used agents, but also the fact that when they also cross-compared quality of life among patients, the use of PARP inhibition rated higher in terms of better quality of life for patients compared to those that used other agents. But having said that, though, like you said, there are still some toxicities that are associated with their use. Some of the more common ones are hematologic toxicities such as anemia, thrombocytopenia, and neutropenia that can in turn lead to other, complications as well. So making sure that you're monitoring this counts as you start treatment. First of all, I try to start treatment and monitor these patients very closely, checking their counts every 2 to 4 weeks initially until they are more stable. And as you move forward and notice any drop in these counts, consider, depending on the degree of anemia, thrombocytopenia, or neutropenia, perhaps cessation temporarily of treatment and resumption at lower doses, depending on the degree or grade of these toxicities. Some non-hematologic toxicities that have been associated with the use of PARP inhibition included nausea and vomiting, diarrhea, or constipation. So making sure that they have available to them medications for supportive care, making sure that antiemetics are available when they become necessary, making sure that laxatives are available when they become necessary. And it seems counterintuitive when I tell patients this, and I tell them there's some sense to this madness, but when you develop fatigue, one of the best remedies actually is exercise. Exercise has been found to be superior to medications when it comes to improving fatigue among patients as it relates to cancer or the treatment for the cancer.
That was a wonderful review of all of those effects. Thank you so much, Grace. Clearly an expert in the clinic who has answered these questions and talked through these situations with patients many times before. So when we think about making treatment choices, I think we all, patient perspective, a nurse practitioner perspective, certainly my perspective as well, is that we do need to have an approach to shared decision-making. And a structured approach is usually the best way for us as clinicians to remember all of the pieces of that process. And, the way that we are thinking about this as among the three of us, at least, is to have an education perspective where the big picture and some of the information about a given treatment is communicated from the clinician to the patient. An emphasize section where we really kind of talk about how there are differences between different treatment options, talking about adverse events. And just as you said, Grace, really that proactive strategy of telling the clinician when those adverse events happen sooner rather than later. And then really equipping patients with the information that they might need to share with their family, with their other healthcare providers, some of the specifics and nuances of a given treatment. And really to understand and have at their fingertips any other supportive medications that they may need to make that process a good one. I wonder, from your perspective, Tony, does this kind of a strategy of structure make sense to you? Is there anything that you think might be missing?
It absolutely makes sense. I think the most important thing that I would emphasize is the fact that patients absorb information in very different ways. Some of us absorb it by reading the written word. Some absorb it by looking at photographs and pictures and diagrams and charts and graphs and so on. So I would just urge people talking to patients, trying to equip them, trying to educate them to think about how they go about that and what the various different types of education might look like. So the use of videos is always very helpful. So just really think about all the nuances of education and how patients will absorb that information, because we don't all absorb it in the same way. I would also add, because we've already mentioned it, the fourth E, which is exercise. It's definitely, in my case, been a vital part of my coping mechanism, both for physical and mental well-being and coping particularly with fatigue. And as a PARP inhibitor is likely to cause some levels of fatigue, exercise will become even more important.
Thank you so much for that. And thank you for bringing exercise back into the conversation. Agree completely. Grace, from your perspective, and I know that you're both a clinician as well as a researcher who tries to make sure that we are improving the way that we deliver care. How does this approach sound to you?
Well, I think I would want to make a comment first to what Tony said about different patients learn differently. So I take that into consideration when I'm counseling patients to make sure I am telling them the information, printing a copy of the information for them to go home with, and also telling them I don't need to have you make a decision right this very moment until you have all the information that you need. So take this home with you, talk to your family about this, and call me if you have any questions, and we can get back to that. But I think research is very important in this field. Clearly we found out about the effects and efficacy of PARP inhibition by conducting research in the use of genetics as we tailor therapeutic approaches to certain patients. I think there's also a big need for us to educate providers. We see, based on the data, that we are still not utilizing the diagnostics and the therapeutic options to the most that they can provide. There's still some providers who are not performing the tests, who are not prescribing the medications, and also educating the public about the benefits of genetic testing as it relates to certain types of cancer, in this case, prostate, and how certain information might be helpful not just to the patients, but the community, their families at large.
Wonderful. So let's each take a minute and summarize what our thoughts might be. I'm going to ask Tony first. What is your summary for this particular section?
I think one of the most important things for healthcare professionals to consider when thinking about their patients is always, in my opinion, to make sure they treat the person and not the cancer. And I think that's a really important part of our treatment pathway. So I will always keep banging the drum about the need for holistic care. And so that's why I say treat the person, not the cancer, not just the cancer.
Well, thank you for that. And Grace, what is your take-home message?
Making sure that they are educated on the options for supportive care. If there are side effects that should arise, give the patients the best chance to do well on the treatment. That way we can get the best outcome from these treatments.
Wonderful. Well, my take-home message is really that this is a partnership that we engage in with our care teams, with our patients, and of course with their families. And we need to think about that whole process, that whole team, that whole group approach as we make these decisions with our patients and support them each step of the way during treatment. Thank you for your time.